Clinical pain syndrome is defined by hyperirritable spots within taut bands of muscle. For decades, diagnosis relied on identifying localized nodules through physical compression. This diagnostic standard was established by Janet Travel and David Simons. Their criteria turned pain identification into a purely sensory exercise for the practitioner. However, systematic reviews show that different clinicians often disagree on the location or existence of a trigger point in the same patient. This lack of inter-rater reliability exposes a core operational flaw in relying exclusively on human touch. When the clinical baseline is this inconsistent, targeting becomes a matter of chance. Inaccurate localization leads directly to suboptimal intervention outcomes and unpredictable pain management for the patient. For MPS treatment to become reliable, the diagnosis must transition from a subjective sensory experience to a quantifiable objective measurement. Diagnostic ultrasound finally provides that objective data. Specifically, B-mode imaging and shear wave elastography allow clinicians to see tissue structures that manual palpation can only estimate. B-mode imaging reveals the hypoechoic signature of a trigger point, appearing as a dark elliptical area within striated muscle. Shear wave elastography adds mechanical evidence, generating a color map to confirm the exact stiffness of the nodule. This technology clearly improves localization, but does that precision actually lead to better patient outcomes compared to traditional blind techniques? To evaluate this, we are analyzing a systematic review of randomized controlled trials, comparing ultrasound-guided interventions against blinded techniques, and measuring the performance of different sonographic modalities. The evidence comes from a 2021 review by Deep, Chen, and Kumbar, which serves as a comprehensive synthesis of recent clinical trials in the field. After an exhaustive search of multiple databases, the authors applied stringent inclusion criteria, filtering the literature down to 11 high-quality randomized controlled trials. To extract clear clinical guidelines, the data must be stratified into specific comparative arms. We begin by looking at ultrasound guidance versus traditional blinded injections. A 2019 pilot trial by Kang and colleagues provides a benchmark here. They measured ultrasound-guided local anesthetic injections against blinded injections in the upper trapezius. At the 4-week follow-up, the ultrasound-guided group showed statistically significant improvements in pain and functional measures. These results were corroborated by a separate trial from Bubnov and Wang, which favored ultrasound-guided dry needling over a blinded approach for pain reduction. The initial data suggests that when compared directly against manual palpation, adding ultrasound guidance produces superior clinical metrics in the short term. If guidance is objectively better, which specific modality performs best when visual localization is held constant? In head-to-head trials, targeted local anesthetic injections frequently underperformed when measured against more specialized interventions. The data shows that ultrasound-guided pulsed radiofrequency and dry needling generally led to better long-term pain reduction and physical function scores than anesthetic injections alone. However, evaluating these results requires looking past simple p-values to the minimally clinically important difference, or MCID. Statistical significance only proves a mathematical difference. To improve a patient's life, the improvement must cross this threshold, and in several trials, the results failed to reach that relevance. Because many estimates remained below the MCID, the statistical superiority observed in the data didn't translate into meaningful changes in a patient's daily function. While radiofrequency and dry needling show numerical advantages, practitioners must filter these trends through the lens of clinical relevance before changing their standards of care. To understand why these findings are so often marginal, we have to assess the structural strength of the randomized trials themselves. The review used the Cochrane Risk of Bias tool to stress test each included study's methodology. This assessment revealed a widespread issue. 7 out of the 11 trials carried a high overall risk of bias, which forces us to view their conclusions with caution. The most prevalent flaw was Domain 1, the randomization process, failing to sufficiently control patient assignment. Domain 5 also showed vulnerabilities regarding the selection of reported results, suggesting a risk that only favorable data points were highlighted. These structural biases are exacerbated by limited sample sizes. Many trials relied on very small groups, which naturally limits the statistical power of their findings. Consequently, the evidence supporting ultrasound-guided interventions should be seen as a set of preliminary trends rather than definitive clinical proof. These methodological questions lead to a deeper biomechanical problem, the assumption that hitting the exact center of the trigger point is what actually provides relief. A study by Farrow and colleagues tested this by comparing ultrasound-guided injections into confirmed trigger points against injections placed deliberately into the adjacent normal fascial tissue. Paradoxically, the study found absolutely no significant difference in immediate pain relief between hitting the target and missing it. This result suggests that the trigger point nodule may not be the primary isolated source of pain in these patients. Instead, the relief might come from regional fascial intervention or the mechanical disruption of the surrounding tissue, regardless of the needle's exact landing spot. Ultrasound provides clinicians with unprecedented precision, but the biological necessity of that precision remains an unresolved clinical question. Even if the target is debated, ultrasound guidance provides a clear safety advantage. Real-time visualization allows advancing a needle while safely bypassing arteries and lung tissue. Furthermore, guided procedures have demonstrated superior clinical outcomes when measured against systemic treatments like NSAIDs and traditional unguided injections. The current recommendation is to use ultrasound as a powerful adjunct to physical palpation, improving safety and short-term efficacy, rather than as a standalone diagnostic tool. Until high-powered, low-bias trials decode the exact mechanism of relief, ultrasound remains the most rigorous tool available for aligning clinical interventions with actual internal anatomy.